Okay, and then it's probably important to mention that for TTAC and CCHP, that they both, and your organization as well, all of them have newsletters that people in the audience here could sign up for to get the latest and greatest from these organizations.
Yes, absolutely. And at the end of this presentation, I actually have some websites and QR codes that'll take you to our national. So we're part of a national consortium, which encompasses all of us. And the consortium is a great landing pad to then find each and every one of us and get signed up for those types of resources and newsletters as well. And so I'll talk a little bit about that at the end.
Great. Sorry to interrupt.
No, you're fine. I'm glad that you checked. Thank you. So what we do is telehealth resource centers. There's two primary focus areas, which is outreach and education, the one-to-many model, and then the one-to-one technical assistance, more specific to maybe some needs for clinic or hospital systems. We provide virtual office hours. We have videos that are helpful for both preparing internally for a telehealth appointment, but then also for patient engagement and patient education. We have a podcast that's available on Spotify and Apple Podcasts. We've just changed the format, and we just published our most recent one under the new format. So check us out. I believe it's episode 21. We like to partner and interview with those that are innovative in the field, that have experience with specific maybe health issues or ways that telehealth and telemedicine has increased access. So we have a lot of great content. We also provide, we're just getting ready to launch our third year telemedicine echo series using the Project Echo model. And then of course, our technical assistance, which is one-to-one support. So a little bit of background leading to what I'm going to focus on today, which is going to be evaluating telehealth readiness within systems. So really quickly, our telehealth priority areas that we focus on, these were pulled together by a lot of the experts that are part of our national consortium. And there's a great website where this information is housed and a lot of great tools. It's the Telehealth Learning Bundle. But we want to make sure that we are addressing each one of these priority areas when we are not only providing resources and support, but also with our readiness assessment that I'm going to talk to in just a little bit. So really quickly, overarching evaluation framework answers the questions who, what, when, how, why, and where. Evaluation, my background is in evaluation, and it's incredibly important to inform on the current state of services, what areas that need improvement, but then also areas that are going really well. Sometimes evaluation can have kind of a bad connotation to it, and people may shy away from it. But it's really an opportunity, and again, I say to celebrate the successes, but then also identify areas of improvement. It's no different in telehealth. There's a lot of research and practice information historically on ways that telehealth has not only improved health outcomes, but also increased access to care and kind of bridge those gaps in accessibility to healthcare. There is a lot of work still to be done in it, especially coming out of the pandemic era. We saw a lot of clinics and hospitals and community health centers and rural health centers creating stopgaps during that time to ensure continuity of care. And now we're in a mode where people want to maintain these services or increase services. So we've worked on a tool that can help determine readiness to do those things. So what we worked on was we wanted to make sure that we were addressing the most up-to-date quality measures. And so we pulled from the National Quality Forum, which is a not-for-profit consistent organization, membership-based, that uses a consensus model of experts across these different areas in healthcare to inform on different quality measures and areas that you can create metrics for improvement. So the Rural Telehealth and Healthcare System Readiness Measurement Framework in 2021 was a guide that we used to ensure we are hitting all of those marks when we're providing the assessment for clinics and health systems. Within this report, there's 5 domains that they focus on, and access to care, technology, business models. But then as opposed to having this long list of domains, and think in terms of maybe workforce training, creating operation models, patient engagement, clinician experience. They actually had a little bit more of a higher level overarching themes, which was experience, effectiveness, and equity, because of a lot of those things I just brought up, those real specific areas, they touch on all of those pieces. And please, if I go too fast, let me know. So this is a quick example of how we created a crosswalk using all of the questions that we had. The eStart assessment was a tool that was used, has been used for a long time with the HTRC. I arrived with the organization and the group in 2022. And as I said before, as we were kind of emerging from the last 3 years and the stop gaps, or sometimes I refer to it as the duct tape of telemedicine services in some clinics that had never done it before, we are reevaluating the questions and taking a look and making sure that it's addressing all of those domains within the NQF framework. So we created a crosswalk with the existing questions. We identified areas that we maybe weren't addressing, and so we are working on adding questions to those areas. And then we also want to make sure we have satisfaction questions related to our process and the experiences that our clients have. So the process really quickly, initially we'd like to meet with the community hospital or clinic, get a feel for what their priority areas might be, what their priorities are with their telehealth services or telemedicine services they currently have. It is a team-based assessment, so we want the organization to pull their team together. They're the experts in their clinics and health systems. We're here to help guide the process. And so we want them to take the assessment as a team. Give them about 2 weeks. That might be a little wishful thinking. I've got clinical experience, and so sometimes it's kind of hard to bring all these folks together to do something like this. But essentially, a 2-week time frame. We have transferred it to an online assessment, so that it's more accessible and a little easier for us to communicate across both teams. We then take a look at the results, and we identify areas that they're really strong in, and then we identify areas that could be improved, and they're aligned with the priorities that they established during that initial meeting. We do check-ins to make sure that they are, we give them the recommendations related to their priority, and they decide what's feasible, what's reasonable, what's attainable, and what would be a good thing for them to start improving on now, short term, and then maybe even incorporating some long-term goals. We do check-ins, we adjust as needed, depending on what they've kind of discovered over that 6-month time. And then we just stay in contact. And then another 6 months later, we check in to see if they've actually, did they achieve the goals that we set forth. Now, this timeline is very, very fluid. It's very dependent on the clinic needs and what they're going to want to achieve and how they set their timeline. But this is just kind of an overarching one-year view of how we can provide that support. One thing I didn't mention early on is, as a HRSA-funded program, we do offer 10 hours of technical assistance, that one-to-one, which is also flexible depending on needs. But those are some of the things that HRSA would like for us to support, and so we do have that available. So this is a overview of the focus areas within our readiness assessment framework, and we have questions very specific to these focus areas. And so, like I said, the team comes together within the clinic and they answer the questions together and then submit it to us for review. This is an example of one question that is under organization governance, because it is really important to have, understand where the organization might be with regards to change and innovation. Now, understanding this can be subjective within the group, but it gives us an idea of what tools we can supply if maybe they need to kind of work with their organizational leadership to find out, to get them in the mood to change or add some telehealth services. Current state, this is a really important question. Are you currently using telehealth? Surprisingly enough, you may think that everybody's adopted some level of service, but there are some that have actually removed services because maybe they don't have the resources available. Their platforms changed, maybe the policy doesn't support it, or there's been a lot of changes in reimbursements and billing that they just don't have the capacity to be able to support it. So this is a really important question that tells us, how long we may need to be involved with their priorities and setting goals and recommendations. How many teleservices are operating? This is also important. If you've got a few that maybe kind of survived the how everything has changed so much, then they may need a lot more resources in building the program, maybe some operations tool templates, training, workforce training and development opportunities. Anything higher than maybe 11, it would say that they're pretty well established and they really understand their services and have the resources needed, but maybe need a little help in some other areas. And then strategy. This is an interesting question. I've actually met with a couple of larger health systems, and one of the questions I ask is, do you have a telehealth or telemedicine strategic plan? And in some instances, they have a robust plan. It's maybe separate of, not necessarily embedded in their larger hospital or larger system strategic plan. And some have standalone. And then in some instances, they don't. And so we can work with them to help develop some very feasible strategies in order to plan for sustainable telehealth or telemedicine services. So the results and analysis piece, we get the results. We take a look at it. The answers are points. There's points assigned for each answer so that they can factor into visuals. I'm a visual person. I like seeing things in a nice either figure or a picture. Some people aren't. And we take that both ways of evaluating the analysis into consideration, because our goal is that this is a useful report. This is very useful to the clinic and hospital, and it doesn't necessarily go on a shelf and collect dust like sometimes these things might do. We will convene with the organization after we have put the report together, and we go through it and answer any questions they may have. So this is a quick kind of very crude display of what the results may look like. So we create this strategy heat, the operations and strategy heat map, if you will. And the answers, like I said, these are the overarching. There's quite a few questions under each one of these subcategories, but it shows where they're really strong, and it shows where they may need to focus their attention, or maybe some resources or funding, maybe incorporated into their financial plan in order to achieve the priorities that they set. Again, this is just a really quick little more individual snapshot specific to the focus areas, but it can show, where they're strong and areas that they may need to improve. So this is just an example of recommendations, because I think that's something that people look for. Okay, these are our results. This is what our snapshot of our organization is right now related to the telehealth priority we've set. Now, what do we do? And so within each area, we have access to a lot of what we call subject matter experts. Example being, I am not a reimbursement expert. That is a lot of work. And if anyone's ever sat in on any of our education series webinars, we have somebody that is fantastic in that area. If that's an area of improvement, then we will reach out to them and we will pull them in and say, can you give us some recommendations within this area of reimbursements, or policy management and advocacy, or anything related to that can help them advance in that area. So these are just kind of quick little examples of things that we may recommend. These will also give us what we need to follow up on. So we know we decided on the recommendations. They're going to test out some of these things that we provided, and then over that timeline, we'll check in and see how they're doing. Okay, that's what I had in terms of my presentation. Do you have any questions for me?
Oh, that's great, Molly. Thank you very much. I might kick it off with what sort of how many candidates for this service are there, do you think? What kind of is your marketplace, so to speak?
So, of course, one of our primary areas of focus is going to be any sort of rural health or rural health, tribal health, frontier areas, those that may not have ready linkages to support. So in rural health clinics, community health clinics, we have some folks that are in Oklahoma that are doing some really interesting things with telehealth access points. So this type of readiness assessment is actually for anybody. What we need to do is we need to get it out there that this is a service that we provide. And it's something that we can at least get started and give them a baseline for their readiness to either add new services or scale the existing services that they have. We can help large health systems in, the KC area. We're here to help any healthcare service that has these goals but doesn't quite know where to start. We've had, I know historically there may have been some clinics that have used this assessment prior to my joining the team, where then they may have some funds or budget for additional consultation that goes beyond what we can provide. So we've seen all sorts of different levels of need related to those that really benefit from this.
Okay. Other questions from the team? I'm not, my view currently doesn't show me any of the hands, so if you don't mind just speaking up, that would be great.
Elizabeth Crocker.
Go ahead, Elizabeth.
Okay. Hi, thank you, Molly, for that presentation. My questions are, in the scope of your services or how you're viewing telehealth, are you including telemedicine as a clinical service, such as, delivery of telemedicine, virtual wards, and the use of remote patient monitoring? That's always a mouthful. How are you differentiating between telehealth and telemedicine?
That's a really good question. I mean, you may have heard through the presentation, I sort of toggled between the two. So we come from the approach that telehealth encompasses all aspects related to any sort of, wearables, education, technical literacy for patient, the end user for patients, like you said, remote patient monitoring, all the different formats of that kind of feed into the whole larger scale of telehealth, defining telehealth, telemedicine being more clinical, telemedicine as a clinical appointment, and more focused in what is needed within clinics to achieve or hold those types of clinical based appointments. And so for me, I toggle between it. We work on this language all the time, and how people go back and forth with it. I'm currently teaching a introduction to telehealth course at the graduate level at KU for our graduate students, and that's one of the things that we talk about. Is you may see it defined as this, but it's really about where you're getting the sources of information. But that's how we approach it within our team. So we kind of do the broader telehealth outreach education in all different areas of learning. And then within clinical services, the telemedicine aspect of it, if that makes sense.
Right. If I could just add on so within that, telemedicine is viewed, and you can talk about that, and if an area wanted to incorporate telemedicine into their whole telehealth strategy, that would be part of that, or if they wanted to do virtual wards or things like that. So it's up to each individual area's strategy, it sounds like.
Absolutely. Because every clinic, they're going to be serving, they're serving their communities. Their communities may have a different profile of needs. And it's really about, yes, that's a great way of putting it. We're depending on them setting their priorities. We don't go in and tell them what we think they should be doing in terms of their service, because they need to be able to achieve it. It's got to be feasible for them to do over that time.
Thank you. I'll be in touch afterwards. Thank you.
Thank you.
Michael Albrecht.
I was wondering if you've ever worked with or interested in working with a physician who would be interested in starting their own telehealth practice that spanned like rural Kansas.
Well, absolutely. I actually have worked with physicians, those that we get all sorts of requests, and sometimes it may be a physician practice that it's a group, and they have privileges at a main hospital in Tulsa, Oklahoma, but then they also have privileges at a critical access hospital in the rural side, and some that may have licensed and privileges in another state. And so we've had inquiries come in like that. And then we can always adapt the readiness questionnaire as well, because you may not be coming from a large system, but rather maybe you're part of a physician group. And how can you then get ready? There's a lot of information related to licensure and reimbursements and how that looks for physicians that are not necessarily housed at a rural health clinic, but may offer services across all different types of systems, if that answers your question.
Yeah, thank you.
Yeah.
Other questions? I might ask, Molly, have you seen any measurable impact of doing these assessments so far?
So, I'm sort of in between. I came in the middle of a lot of these changes. There was a lot of work being done with this assessment prior to my joining the team. And what we've done is took me a good time to get acclimated as the new director, but then also bringing in my evaluation background and then pulling in all of these different frameworks and experts to help kind of inform on it. So, long answer to your question, I'm sort of restarting this, if you will. We are going to be working with a federally qualified health center that I have a long-standing relationship with. And we're going to be working with them following this process model that I shared today. And we're going to be working on ensuring we get some of those kinks worked out in the process. The goal being that this assessment is going to be shared with our national partners at the consortium, something that they can use in their own areas. And so what I'd like to do is really monitor this process and get some of those measurable data points that you talked about to see how it's impacting different clinics in rural areas, larger hospital systems, and then measuring the change over time, if that answers your question. So
Yes,
do I have a lot of input now, of a lot of data that I can look at? Not yet, but that's the goal.
Okay.
Well done.
Did you say you had some links to share?
Yeah, so let me get through that really quick. So we have two HTRC sponsored webinars coming up. One is related to licensure and some of the DEA prescription rules, and then the deep dive coding, specific coding for reimbursements. I heard social determinants of health mentioned a couple of times with some of the partners on this call. You may have seen that the Centers for Medicare and Medicaid now have codes for clinics to be reimbursed related to social determinants of health. It's new. And we're working on taking, how does that work? How would that work for a clinic? And how do you have to code so that your reimbursements are efficient? You're not getting them kicked back to you. So one of our experts, this is what she does. And so we have these two presentations coming up. The National Consortium, as I talked about, they have a monthly webinar series. They pull from experts all across the country. And so you can go to this website and sign up for their newsletter, but then also sign up for their monthly webinars, and you can attend as needed that fits your needs. And then lastly, we partner with our TRCs to the north. We have the Telehealth Everywhere conference coming up in May. It's a great conference, and we're going to hopefully start working on, our idea is to then alternate where we actually have these conferences. And we're looking at our 2025 conference being in our kind of Kansas, Missouri area. So it's more attainable for folks within our region as well. Today's the last day to sign up for the early bird special, but I wanted to share this with you in case you had any interest of attending, and you can go visit the agenda.
Great.
And then you can find us, if you go to heartlandtrc.org, we also have the connections to those national TRCs that John spoke of. And then also you can sign up for our newsletter as well.
Is there a link there? I guess I'll share it myself now, but there may be a link on the page as well to your YouTube channel.
Yeah, it's through our it's easiest to kind of land on our website, because
Okay.
then you can see all of it. I'll drop some things in the chat too during the rest of the meeting.
That'd be great. Yeah. I have, just speaking to the group, I have had the opportunity to attend a number of the HTRC educational sessions, and there have been a whole series with expert Rochelle Marting. She is just excellent in terms of knowing everything to do with billing and coding and how it really works under telehealth. And so she has done an excellent job, and there's quite a series for you to refer to in the YouTube channel.
We keep Rochelle busy, yes, and we also take specific requests for your clinic. So if you are if you have a touch point with any clinic or anyone that's providing telehealth or telemedicine services, has specific questions, just send us an email. I'll put our email in the chat as well, and we get those answered for you. It's part of what we do it's part of the services that we provide.
Great. Thanks so much, Molly. Okay, just a couple of people have joined us since we started. I'll give them just a chance to say hello and they give their name and organization. Angela Gifford.
Yeah, good morning, everyone. I'm Angela Gifford. I am currently working at Red Point Summit. So I attended one of the events a couple months ago, and this is my first time joining one of these monthly calls. So it's nice to meet everyone.
Great, thank you. Dr. Ader? Dr. Ader may have stepped away.
Actually, sorry,
Okay.
I'm back. Greg Ader, CMIO at KU Health System. Thank you.
Great, thanks for joining us. Okay, I'd like to introduce the team from Just Ask Evie to make our presentation to us. It's a great solution for taking the stress out of a clinician's workflow, and I invite Dr. J.D. Tyler to take us through it.
All right, thank you. Can everyone see my screen?
Yes.
Am I on the right screen? Perfect.
You are.
All right, thank you. All right, so EMR-induced burnout is not a fallacy. This is what it's all about right here. I know it's kind of a buzzword lately, but if you think about it, everyone on this call, everyone's health largely depends on the well-being of the healthcare workforce. So as a former CMIO and physician, I've experienced firsthand that physical, emotional, and mental exhaustion due to the challenges associated with the EMR, and that kind of led me here today. So as I mentioned earlier, introduced myself earlier, JD Tyler, I'm a MedPeds doc, and here to share my journey on from practicing medicine, working in healthcare IT, and developing EMR IP, and then now becoming the founder of Just Ask Evie. So when I started my medical training, I mainly used paper charts, but by the time I was in private practice, I mainly used the electronic medical record. And so I noticed as my skills as a physician improved, the EMR became my bottleneck of the day. So in every role that I've had in healthcare, there was that one consistent problem, and that was learning and asking for help regarding the EMR was never easy. And when I did get help many times, the quality of that support wasn't all that great. And that eventually took a toll on me. So here's the harsh truth that people may not realize. Healthcare burnout is pretty rampant. Nearly a quarter of doctors and about 40% of nurses are set to throw in the towel in the next 24 months. And that's based off of surveys that were done for those two roles in healthcare. And about 63% of physicians feel emotional exhaustion or other burnout symptoms every week. And if that's not enough about the usability of EMRs earns a big fat F, and about 40% of burnout cases are caused by EMRs. So 70% of physicians blame the EMR for the uptick in their administrative workload. And then to top it off, doctors now have one of the highest suicide rates of all professions. And so all of these numbers really point to the fact that none of this can be ignored. So for example, If nothing were done to address burnout, almost 60% physicians would leave Stanford Medicine within 2 years. And this is data from Stanford. The cost to replace a physician, depending on their specialty, ranges from about $250,000 to almost $1 million. And that includes costs for lost billings, cost to recruit, sign-on bonuses, everything. And so if you were to look at those 60 physicians, it could end up costing Stanford anywhere from 16 million on a conservative side to possibly $56 million just to replace those doctors and provide the physicians they need in order to care for their patients. So it's a not only does it have a impact on healthcare in general, but also a financial impact on healthcare systems as well if they don't address burnout. And so I just wanted to go ahead and use this interactive part here. So if you use the raise your hand function in the chat, raise your hand if you've ever heard a doctor, a nurse, front desk employee, anyone else in the hospital or clinic express frustration with the electronic medical record. And I'll pause and let you guys. Only a handful of you guys, right? So obviously, even if you're not in healthcare and you're a patient, you probably heard it from the front desk person or someone you're calling. So it's pretty rampant, and so something has to be done, right? So how do we change? How do we turn the tide on this problem? Where we begin to create a brighter future and give providers time back to their patients. And so you got to start chipping away at the administrative burden that they carry. And even our nation's Surgeon General has a goal of reducing providers' administrative burden by 75% by 2025. So that's pretty significant. It's pretty big goal. In order to do that, we're going to have to significantly enhance EMR usability, prioritize time with patients rather than type and click tasks, and we have to leverage technology to accomplish all of this. So I personally would love to conquer all three, but I'm going to focus on just the technology that can make it better. And as Dr. Grass says here very eloquently, although one intervention can't magically change everything, some easy changes will add up to hours of saved time for busy physicians. And that's really kind of what we focus on. So I want you to imagine, if you understand the workflow in the electronic medical record, great. But if not, imagine, when you're seeing that your physician or nurse practitioner and they're in front of the computer and they have that frustration, or maybe they're perhaps not even showing the frustration, but they're showing some pausing. Imagine for that particular provider if there was just an easy button in their EMR. So no phone number to remember, no waiting on hold, no emails, tickets, forms to fill out, just right within their workflow, a magic little button that gets them the help that they need, the high quality help, real-time help right then and there. So that is Just Ask Evie. So when they click within their electronic medical record, whether it be Cerner or Epic, whatever EMR they're using, they'll be taken to just a simple help button. So we have a patent pending algorithm that understands who this person is, where they are, what they're using, and it will triage basically that request to the appropriate person. So if you're looking at my screen now, is it showing the help button on the left? It is good. Okay. Yeah. So on the left side is what the provider, the nurse, anyone sees when they need help. On the right side is a support person. And that support person could be the internal support team, or it could be somebody on our team. And our team is a network of peer super users. And so that is a physician or a nurse who uses that particular electronic medical record every single day. And many times at their own organization, they are a super user. They help with the training. But all that is needed from the physician or the nurse is to hit the help button. What will happen is it goes to a queue. You heard my phone there. I matched for this particular person. I can help this person with an issue that they have. And so that turns into just a simple text message or push notification from that phone, the person who's providing the help. They're not tethered to a computer, they're mobile. They can accept that request, call that person right back. Our average response time during the day is about 45 seconds. After hours, it's less than 2 minutes. And they're able to connect over the phone that quickly And then very easily, if they need to share that to see their screen, they can share a link for a secured screen session. And then all of a sudden, within seconds, they're actually looking at the screen, providing virtual at the elbow support. And it's high quality because it's peer-to-peer and it has that empathy of somebody who's walked a mile in your shoes. The information is gathered in the session as to what the question or questions are being asked, and that's saved to our database. And so as a byproduct of those interactions, we're able to kind of use that data going forward. But keep in mind that the person who needs help, all they've had to do so far is hit a help button, answer their phone, click a link to share their screen, and they're getting that, which would typically would take, you know, even longer to get a hold of somebody. You're probably waiting on hold longer than you would be able to actually talk to somebody and share your screen with us. Once that session is complete, it's simply reset, so if they can hit the button again if they wanted to, and they're taken right back to, you know, they get back to take care of their patient. The nice thing from this is all those interactions are captured and available to the health system in our workflow analytics dashboard. So each EMR has an analytics tool, and it really acts as a kind of what I describe as a full body CT scans. You know, it lets the health system know that there is a problem, but not really what the problem is. And so our workflow analytics gives insight that you cannot get easily or accurately anywhere else. And so we provide a dashboard and detailed reporting. So what you see is our dashboard. It gives information on who's asking these questions, what specialty, what kind of questions are they asking, what's the first contact resolution, which of these actually became tickets, session length, response time. All these widgets can be customized for each client. And then also the activity. So the organization is able to not only leverage their own internal team more efficiently, to be able to say, you're really good at answering these questions, you'll only get requests for that you can answer, and also be able to provide, you know, an idea of when are we the busiest, so we can use our own staff appropriately. And then on our staff, it's a seamless handover to our team for after hours and weekends and for support. So a health system's able to provide 24/7 support without spending a lot of money. You know, we offer fractional work after hours. So when it is used, that's whenever it costs money. And it's every 15 minutes. So it's really, really cost effective. That's me again. Really cost effective for healthcare systems. And so this is our approach. You know, our team of peer clinicians that have that empathy. They walked a mile in those providers' shoes. They understand that frustration firsthand. We also understand that, you know, the tight budgets of hospitals and clinics, which is why we offer the platform for the local team to help them optimize that staff as well. And then we go with the workflow, right? So that's where our support is. We've designed it to the support to be in the workflow, not around it. So it's very easy for them to ask questions. It's fresh in their mind. They learn from that experience. We look at our data and we see that there are repeat users, but there's not repeat questions. And then lastly, we allow the organizations, help the organizations use the data from the platform to provide those insights that can be turned into actions to, you know, improve the EMR experience, whether it be an EMR build, improvement of order sets, favorites, whatever you need, as well as help healthcare systems improve their onboarding. They can look at that data and say, hey, everyone's really struggling with this particular area, so let's improve our onboarding so that we address this before it's an issue. We even offer our platform to be available inside the training environment at a healthcare system, so that with somebody who's new and starting, when they're going through that initial training, if they get stuck, they're able to hit the button, get help right then and there, you know, really, you know, nip that in the bud, so that they understand and learn how to use Epic or Cerner from the very beginning. So that's really key as well. That's it. So, you know, that's our approach. That is, you know, kind of what we solely focus on, is that improvement of the EMR experience and support. The results that we've seen have been great. Improvement in the efficiency and proficiency, clearly improvement in satisfaction scores of EMR use, and health systems have seen that benefit of being able to, do that initial training and onboarding much more efficiently for their clinics that they acquire, or for any new physicians or nurses, I should say. So I'll pause there and answer any questions you may have. I see Scott with his hand up, but you're on mute, Scott.
Hey, JD, I'll jump in here. Well, that's coming. One of the things that struck me about the work you do is how much insight you actually have at the point of frustration. A lot of the data we've gathered as an industry is in post surveys, being with your physician, discussions in the physician's lounge or provider's lounge. And I think you've got some nuggets of gold there. You touched it a little bit about, hey, people don't call back for the same problem. That's an incredibly valuable insight. And you've got very important lists specific to an organization of areas where they either didn't do a good job training, if that's the problem. I'm not saying training is a problem, or something that's not well engineered. And companies like Redpoint and lots of others, as you said, you're not trying to solve all the problem.
No.
But anyway, you have a really unique set of insights and frankly a data set to back it up. So I wondered if that's prompted interest from the provider and client community in those kinds of insights.
It has. I think, we probably should talk more about that only when we do our initial kind of conversations. It's kind of discovered probably a month or 2 or 3 into their journey of using Just Ask Evie. What we discovered was, if you give a physician, a nurse, really anybody, an easy way to ask for a question, there's a lot of unasked questions that now are starting to be asked. And I think that's really good, because that means the physician, the nurse, they want to be a super user. They just didn't have an easy way to ask for that support previously. And now that you're giving it to them, they become more polished users, and they're happy with that. Another thing that organizations realize are just how much people don't read their emails or pay attention during the meetings. And so I give this great story of UPMC that they did an upgrade. They did all the typical traditional thing where they sent the email out, they mentioned it every meeting, and lo and behold, they gave us a heads up. They said, we're upgrading on Monday. And in fact, we anticipate a large influx of requests. Can your team start earlier in the day and help us cover? And so we made that change for that one day. And then from there, it basically, majority of the questions that came in were just simple things like, where'd my button go? And, when did you do this? When did this change? And of course, it's buried in the email somewhere in their inbox. But that was a very easy request, easy solution. And the answer was given right in real time. And then what we do on our side, and we recommend the health system do this as well, we call them EVs, right? Because it's called Just Ask Evie. We tell them, answer that initial question. And while you have their attention, probe them a little bit. Ask questions, because they're a peer, and offer to help them make an auto text or smart phrase. Ask them, how are things going? Is there anything else they can help with? Many times the physician or nurse, they will say, kind of like a patient, they'll say, hey, now that I got you, I always wondered this. So they want to learn, and it's an open environment to where they're able to have that conversation. And I tell every Evie, your job is to make that person a super user just like you. I want you to give all the tips and tricks and make their life easier so that they can get back to taking care of patients and not frustrated with the EMR. And we've got great success with that, to where our satisfaction scores initially were 4.1 out of 5, which I thought was amazing, because that means there's doctors out there giving us 5 stars, which, as physicians, we never get 5 stars. And then went from 4.1 out of 5, and then after some enhancements, and it went to 4.3 out of 5. So it actually improved. And so, we're able to provide kind of the organization an insight, kind of the pulse, kind of the, the mood of the health system when it comes to that EMR workflow.
My question was going to be, thanks for the presentation, Dr. Tyler. My question is, Are the societies taking notice of platforms like yours, and how are they supporting you? One, two, are you considering or contemplating taking the elevator down to medical schools to get in earlier with physicians in training to understand there are resources available to them? Maybe they don't have a tremendous amount of experience in computational sciences or or interface to take elective courses, or at least exposure to this type of resource as they assimilate into their fields of discipline.
I have not done the latter. The former, we are talking to. I'm on a HIMSS physician burden reduction task force. So we've kind of working through that. We've talked to class several times, and then we actually, a lot of the data that's being collected, especially at UPMC, and then going forward, even Indiana University, presenting at AMIA and AMDIS, that's kind of on their schedule to do, because they see that value of imagining being able to do 24/7 clinical informatics rounds, and being able to, but have it be the opposite. If you're not familiar with informatics rounds, I led those as a CMIO. You're basically with a team of people walking through the clinic or walking to the hospital and asking people, "Oh, do you have any questions?" And usually it's probably one or two questions that entire time. When you reverse that and give the power to the person who needs that, who is asking for it, it is much more effective. I kind of equate it to, putting your hand up when you need a taxi versus using the Uber or Lyft and hitting a button whenever you need that. So that's kind of what we provide, is that on demand. But I would love to work more with the societies to be able to address this, even here locally with the American Academy of Family Practitioners. Just being able to provide that insight and provide that help, because this is an issue at every part of healthcare clinicians. Everyone has to use the electronic medical record. It is a tool that everyone has to use, and I would say it's probably the tool that is supported the least when it comes to training and adoption. Everyone thinks, oh, it's an EMR, you're smart, you'll figure it out. The reality is they'll figure out a way to use it, but probably not the best way to use it. And for the clinicians on the call, it's kind of like when a medical student first gets their stethoscope and they put it in their ears the wrong way. Now you would think, oh, it's so intuitive, you just put it in your ears, you know how to use it, but there's actually nuances to it. And the same thing with electronic medical record. You can click around and find your workflow, but that's not to say it's the best way to use it. And so that's what we provide, is that platform to connect them, as well as the resources if needed. So we're kind of supplemental resources. It's a very long answer for your short question, but I hope it answered it.
Thank you.
Yeah.
Dr. Albrecht?
I just had a question on the age of the users. Are they mostly kind of older clinicians, or a lot of millennials as well? And are there more physicians using the product, or nurses? And are there like physical therapists and pharmacists using the product as well?
Yeah. So typically, organizations will start with the provider. They're probably and I'll use Christine's because I love how she says this. The loudest crying child is the physician. So they'll start with that first, but they'll very quickly realize, oh, this makes our support team's workflow much more efficient. So they expand to everybody. But looking at the data, it is used by physicians and nurses almost the same amount. But if you think about it, there's more nurses than there are physicians. So it's balanced in the amount of use. As for the age, we don't know what their age is. That's one criteria that we don't know. I will say it is used by everybody, even from residents on to physician, senior physicians. The consistent part though is they don't know if it's a workflow issue or it's a technical issue. And I think that's what we've learned as well, is we don't want them to try to figure that out. If they're stumped, hit the button. And the person on the other side, they will help troubleshoot that. And if it ends up being a technical issue, that person's able to usually give them a good workaround until it's fixed. But also we take that burden of logging the ticket off of the end provider. We actually integrate into the ticketing system of that health system so that we can capture the appropriate information and log the ticket on their behalf. That works out really well because physicians, probably nurses, but I know physicians do a horrible job logging those tickets. So if you're not familiar with what a ticket is, it's basically like, oh, here's my problem. And usually physicians say, I can't sign my note. And that's all they put in their ticket. So that causes a big back and forth and correspondence that never really follows up. And so that ticket floats out in the ether until it just expires and nothing's ever done. We're able to, with our team, they're savvy enough. We automate or integrate into that ticketing system so that it's a high quality, what I call a high quality ticket. It has all the details, information they need, so that need for correspondence is less, and the issue is solved. So I tell you that because it may be somebody who's young and savvy and knows the EMR really well, but they still get stumped. And so what they'll do is they'll click this, and I don't know if I'm doing something wrong or if there's something broken. And they'll need another brain to help them kind of troubleshoot. And at the end of it, the result is, is a ticket. That guy could have logged a ticket before, but now he's just a better experience. And it's comforting for that physician because they can say, okay, good, I'm not crazy. You see this problem too. Oh, you're doing the ticket for me? Great, I'm gonna go back and take care of patients. And so that's the experience that we want. So I don't know the age of them, but I know that nobody is excluded, and everyone gets the benefit of it.
Dr. Ader.
Yes, hi, JD. Great talk.
Hey.
This is a great concept. I really do think we've got a crisis in this space of suffering saints, I call them.
Yeah.
And I really think Dick's comment is something I'd like to kind of, what we find consistently amongst our 2,200 providers is that people don't know what they don't know. And I think this transcends the EMR. I mean, I think it's a part of a complex socio-technical system that an EMR is. But have you looked at potentially trying to figure out from the data crumbs who needs help, and sort of when they interact with you, sort of be a bit more proactive than reactive? Any thoughts on that?
Yeah, so that's the nice thing about I meant to mention earlier when it was asked, are pharmacists using it more, or we're able to separate those roles so that we do present that in our dashboard, and so you're able to look at that information and categorize not only who's having the questions, but what are their questions. What are those categories? Is it a charting issue, a billing issue, chart closure issue, and be able to look at that. And we are able to look at that and say, hey, this is an issue where there's a lot of questions coming in from the surgeons regarding this. And so that is something we will anticipate in the future. So we should really focus on this part for those surgeons. I will say, there's always a lot of talk about AI and machine learning. I had a role as a chief medical officer for a wound imaging company. We used a lot of AI and machine learning for wound documentation and wound imaging. So I'm pretty passionate about it. Where we see us leveraging AI is on that data aggregation and making sense of that and do that predictive analytics, kind of what you're talking about, Dr. Ader. That's where we're leveraging it. We don't want to leverage it on the front end, because what we really provide is that empathy and that understanding and being able to give that pulse, that mood of the organization. But to answer your question, yes, we are seeing those trends, and those have been really helpful. So you can be able to say, here the ophthalmologists have these issues versus here's what the family practitioners or the internal medicine team, here's their issues, and able to use that data to dictate going forward what should we focus on training, what should we focus on their particular EMR experience and their EMR build, and have objective data to drive that versus anecdotal, which is, well, they complain a lot about this, and we're able to provide kind of the smoke, before there's actual fire. Does that make sense?
Yeah, that's great. Thank you.
Yep.
Dr. Johnson.
JD, I think you've got a really great product and resolving a lot of issues for those jobs to be done at the physician level, the nursing level within organizations. It's definitely needed. I'm wondering if there's an opportunity to take it further, where not all of the issues with the EMR are at the physician or nurse not knowing how to use the workflows that are set up, but also the way the organization has set up the EMR to provide more burdens and road stops for those using it. The AMA has a great organizational framework for how to decrease the burden, but it is it's targeted to the executive level, the leaders within the organization. And across my work across many states, I'm finding that a lot of the leaders of organizations have a disconnect with what's understanding of what's going on at the ground level for physicians, and don't recognize that so many of the workflow processes are hampering them, such as how much is in that in basket and how much could be offloaded to non-physicians, non-nurses, how much doesn't even need to. So a lot of those things are at the higher level. It seems like your product and service is sitting at this crossroad with actually bridging that gap between what's going on the ground floor and what people at the higher level can change their workflow policies. I'm wondering if there's an opportunity to also include when physicians and nurses are using your service to say, hey, you know what would be a really great workflow improvement is, can we get all this stuff out of my in basket? And then to take all of these recommendations and have an opportunity for those in the IT world within the organization, or the champions for EMR improvement who have the ability to make decisions to make some of those process workflow changes for the organization. Have you thought about that as some next steps?
Yeah, so two great things that you pointed out. One, I will say some health systems are aware that they don't know what their issues are, and because we every time we meet a new organization, we say, like, what problems are you having, and some are just flat out, blunt with us and say, we don't know what our issues are, because nobody will. Nope, we don't have a way to capture it. No one will log a ticket. No one. They call it the no help desk, so they don't want to call the help desk. And so, we don't find out our issues until they've blown up in our face. And so we don't know what our issues are. And then the other side of the spectrum, there are people who are just saying, like, oh, everything's fine. It's kind of out of sight, out of mind. We have a help desk for them. And I was like, well, are they using it? Like, but we have it. And so but you're absolutely right. There is that most times there's that disconnect between what's on the ground level, the troops there, and then the leadership above. And we are that bridge to say, let's just give them an easy way to ask. And to your second point, many times we'll get that feedback just from the physician or nurse. They will say, I wish it did this. And so, but we never, I like your idea of maybe always asking that, like, anything else would you like anything else to be able to do from here, like a better workflow and kind of like be more proactive versus right now we do capture all that information. If they say, I wish it did this, we log that as kind of as a, under the question part, but it's kind of a request enhancement. And since it is a peer that's on the end, or maybe internally a support analyst, there is that conversation of, oh, that's interesting. Why would you want that? And that's always where I come in. That was my job at Cerner, was just like kind of the person between the healthcare systems and the architect and the developer. It was being able to say, that's a really good request. Why are you asking that? Like, what do you think it would help with? And so digging deeper, I can see us doing that as well. It's kind of naturally happening, but we can be better at it, be more proactive and a probe and say, hey, anything in particular in this workflow that you wish was better? I think that's valuable information, not only for the health system. I know that each health system is kind of constrained to what they're able to do with their own EMR. So I think it's actually really valuable for Oracle to be able to say, I can give you real-time user feedback. Whereas when I worked there, when it was Cerner, it was hard to get that feedback. I remember we would bribe people with all kinds of gift cards and everything we could just to get that feedback. Whereas right now, it's very passive. We have a very we're approaching 10,000 questions to be able to provide feedback on, and that's just, I say 10,000 questions. Actually, it's over 10,000 right now. We have about 9,000 interactions, so way more than 10,000 questions actually. So we have that data, but I like your idea of being more proactive with it.
That's great. So, any other thoughts before we close? Well, thank you, JD. That was really excellent.
Thank you.
Yeah, we are grateful for your time with us at the last Digital Health Innovation Forum. We really appreciate your support and your contributions, and just real pleased to see how Just Ask Stevie is going.
Yeah, thank you.
Thank you. Let me just do one other thing before we stop here. We got a couple of announcements. Let me bring up one for us. Just a second, please. This is just the announcement on our events page for the next forum on March 6th in the evening, called Toward a Connected Health Community. Wanted to give everybody a chance to kind of come out and hear some of the things that are going on, particularly with respect to social drivers of health in the community, how people are responding to it, how they're thinking about it. My own opinion and where we came up with the title is that the direct ability to connect across both social services and medical services really provides an opportunity for us to be more connected across the community than ever before. And so this is just kind of a fundamental aspect of how we go forward in our practice and in how we build out the community. So we're looking forward to seeing all of you there on March 6th. There'll be some refreshments and some networking time, but it's also a really nice in-depth discussion. So welcome to everybody. I'll turn it
John,
over. Go ahead.
Let me just make a, so KC Digital Drive is a partner of Digital Health KC. And we're fortunate, you guys probably saw the announcements. We got a significant grant from the Department of Commerce with matching funding from Kaufman. And that's allowed us to really ramp up significantly the programs in support of early stage companies and broadly in support of the ecosystem. So along with UMKC Center for Innovation and Digital Sandbox and all the great work they do, all the great work that's being done by KC Digital Drive in their healthcare sector with Jim and John, and Pipeline, which is an early stage entrepreneurial kind of cohort and helping companies grow. And in our case, what we've done is not tried to create lots of new organizations and lots of new administrative overhead, but to go to those folks like John and KC Digital Drive and one, give them some funding that is kind of a pass-through from our grant work, but really to help bolster programs exactly like what John's doing today on a monthly basis, and then the quarterly programs that he's running as well. So if you're not following us in LinkedIn or looking at our programs or haven't registered or any of that kind of stuff, let us know at digitalhealthkc.org. And we'll continue to support these programs, and we'll have unique programs and meetups and coffees and all those kinds of things as well. So this is a great group of people, John. We got to get everybody's name. We got to make sure they're on the distribution list so that we can continue to see some of these faces at upcoming programs. Because the goal is we got something really special here in Kansas City and the ability. We've got lots of talent. We've got over 110 companies that are working in the space. We are one of the most important places to do digital health in the United States and the world. We're just not recognized for all the great stuff that's done. And we're going to change that over the next few years to make this the place to build and grow great digital health companies that change healthcare. So thanks for all you guys are doing. And John, thanks for a little time to tell that story.
Oh, no problem, Dick. Thank you very much for contributing. I appreciate it. I'll turn it over to Doug, who has a few announcements. Go ahead, Doug.
Yeah, just 30 seconds. One is just want to update that Kansas City AI Club is going to be hosting at KUMC Health Education Building at KU Med on AI and healthcare. And so there's a $10 donation for that, but would highly recommend attending that event. They have meetings once a month, and the next month is AI and policy. So that's if you're interested in AI around healthcare and other areas, that's a great organization to be involved with. And then the second one I just wanted to highlight on February 20th, we're going to have it at Flip Switch, is downtown Kansas City. It's actually an AI gaming event area, but they have a nice venue. And we've had that last year as well. But the VRAR Association and KC Digital Drive is hosting this event. I also put that in the chat. But the one thing I really wanted to highlight is we're going to have a focus on it's going to be on workforce development, but we have the Kansas Nursing School Nursing Workforce Center, Dr. Amy Garcia, talking about the workforce development and AR and AI, along with Nick Spalata, who will talk about healthcare and AI adoption as well. So and also we're hoping to have an Apple Vision Pro there. So and actually we are looking for other speakers that will talk 5 to 10 minutes. So if you are interested in speaking, please let me know. And it's focused on around the workforce development and AI and VR. So if there's a tie into that, happy to have you to be part of that group. And just attend, is free event to attend. So thank you.
Great, Doug. Thanks very much. Well, thank you all for your time and interest today. We really appreciate your contributions and your, I guess I would just call it teamwork, where it's something that's meaningful for the community, and we're glad to have everyone involved, and look forward to seeing you at coming events.
Thank you.
Thank you.
Thanks,
Bye now.
John.
Thank you, everybody. See you guys.
Thank you, John.
Thanks.